Everybody, a very good evening to all of you. I'm Dr. Uday Bhanu, and I will be helping you with basic physiology, oral histology, and undoubtedly one of the most colorful subjects, literally and figuratively, that is oral pathology. So first of all, let's address the elephant in the room. Most of us have always been at crossroads with oral pathology. That is because theoretically, it's relatively easy to comprehend and memorize. It's more of a memory game as far as the theory is concerned. This applies both to our undergraduate training as well as to our postgraduate entrance training. But when it comes to identifying histological specimens, histopathology, when we come to viewing slides, it's a totally different ballgame. So it comes to be more of a love-hate kind of relationship. So here we have to decipher what the cells are trying to tell us under the garb of blue and pink. That is your hematoxylin and eosin respectively. So this part is what often gets us caught out, especially when we consider the newer samples of questions which are arising in the past 2-3 years. We have seen a lot of questions which are image-based. So we have to have a thorough understanding of how the histological specimens appear for us to make the most of the scores and our training over the past few years. So this understanding will eventually decide whether we like the subject or whether it turns out to be our greatest nemesis. On that note, we will be trying to decipher certain codes in oral pathology, that is certain basic appearances which we come across on routine histopathological examinations. This is what we will be trying to understand today, so that this will form the basis for our further understanding in this subject. So whenever we come across histopathology, the first thing, at least in our undergraduate training, the way we identify different spotters was through cracks in the cover slips or through broken slides. It was never through our routine histopathological features, which we took the time and trouble to study from in the textbooks. That is because everything looked pink and blue. But it is only when you start listening through your eyes, that is when you start understanding what the cell is trying to tell you. Because cells happen to be the most dynamic entity ever. And since even though most of our stains are non-vital, that is, those cells are dead, even then each and every cell, be it normal or be it in a state of pathology, is trying to tell you something. The more you can read into their cryptic language, the better posed you are to make a better diagnosis. So always listen with your eyes. And the second thing is to know what is normal. That is the basic requirement. For this, you need to have a thorough understanding of your basic oral histology. It is only when you know how a normal cell looks can you identify it and distinguish it from something that is abnormal. And only this can guide you in the right direction. So the different factors which determine normal histology and its deviation towards pathology are 4 in number. One is the number of cells. This is primarily decided by the turnover of cells. Turnover means the normal number of cells which you would associate with a particular tissue. For example, let's take our buccal mucosa. There is about 8 to 12 layers cell thickness. This cell thickness has to be renewed at a regular interval. This regular interval in which the entire cell population, right from the basal cell layer up to the stratum, the surface stratum layer, the entire cell population has to be renewed. This time refers to the turnover time. And within this turnover time, a fixed number of cells are replenished regularly. So whenever there is a pathology, the number of cells changes. It increases or decreases or may be totally absent. So that is the point number 1, which is the number of cells. The second is the nature of the cells. What type of cells are present there? Are they inflammatory cells? Are they epithelial cells? Or are they giant cells? So that determines the nature of the environment in which that cell is residing. Then we have the size of the cell. Now, you should have a basic idea as to what is the normal size of a particular cell. For example, for reference purposes, let's talk about the epithelial cell. An epithelial cell, you should have a basic idea in your mind as to how a normal epithelial cell looks. What is its shape? What is its morphology? What is its normal size and dimension? Only then can you identify variations in the size and structure of the cell, which is also known as pleomorphism. This can be identified only if you know how a normal cell looks in size. Now, all these factors together will influence the arrangement of the cells. So normally a cell, again we are taking epithelium for reference, normally cells appear to be well stratified. Stratified as in they will be arranged in systematic layers. However, if cells undergo change in number, nature or size, the arrangement of cells can vary. So you will find hyperplasia, atrophy, or even ulceration of the epithelium, for example. So you will see variation in the arrangement of cells. So here you have to know what is the normal arrangement of cells so as to delineate it from various pathologies. So under the microscope, there are two basic aspects of a cell which you can identify and study very closely. One is the nucleus and the other is the cytoplasm. Now the nucleus, or the staining pattern of the nucleus, a nucleus is hematoxophilic. That's the first basic point. These points which I'll be telling you today is part of an orientation. They may seem very simple, very basic, but they are vital for your future training. So a nucleus will be hematoxophilic. Hematoxylin is blue. Eosin is pink. Hematoxylin stains the nucleus. So the staining properties of the nucleus, or the staining characteristics of the nucleus, determine the nature of the cell or what the cell is going through. On that basis, you have three distinct parameters. The first one is an open-faced nucleus, also known as a vesicular nucleus. If you can see the staining pattern here, note the nucleus here. Please observe my cursor. If you can see the nuclei here, they are much more translucent, and you can see these small vesicles present within the nuclei and these violet dots which are dispersed throughout. This is known as euchromatin. These dots, these blue concentrated dots, are euchromatin. They represent the active genetic material within the nucleus. So this vesicular nucleus, or an open-faced nucleus, suggests that the cell is secretorily active. That is, it is either busy producing a particular secretory product, or it is in the process of planning to undergo multiplication. So it's an active cell. Basically, a vesicular nucleus suggests an active cell. Next, you have a closed phase nucleus. A closed phase nucleus, or a hyperchromatic nucleus. Hyper meaning excessive and chroma meaning color. So see the nuclei here. It's completely blue, isn't it? You are not able to see this translucent nature. Neither are you able to see the dispersion of euchromatin. That is because here the genetic material is much more inactive and is in a state called heterochromatin. Heterochromatin is genetically inactive and does not play a role in secretory activities. This suggests that the cell is in a state of rest. It is not involved in any activities whatsoever. So anywhere in basic histology, now you may even see open-faced nucleus even in your basic odontogenic histology. If you see an odontoblast exhibiting a vesicular nucleus, you can be sure that it is going to take part in dentinogenesis very soon. However, if the nucleus is more hyperchromatic or dark staining, it is more suggestive of the cell being in a state of rest and not being active in any secretory functions. So these two are the normal parameters of a nucleus. Hope this concept is clear to you, right? So now we move on to a variation from this normalcy that is called pleomorphism. Pleomorphism is not a normal feature. Pleomorphism is not seen in routine histology. It is seen in histopathology. So here you find pleomorphism is wherein there is a variation in the size and shape of nuclei of adjoining cells. So please take a look at this picture. This is a histopathology of a malignancy. So see the nuclei here, they are large vesicular. Here it's kind of hyperchromatic. Here it appears very large. Again, it is hypochromatic here. So it's never consistent. So that is suggestive of pleomorphism. So you will come across pleomorphism in a wide array of pre-malignant and malignant lesions. For example, starting with something as simple and common as epithelial dysplasia to something as morbid, potentially morbid, as oral squamous cell carcinoma. So at this point, you should know the variations in nuclear morphology. Hope this point is clear to you, right? So we'll move on, okay? Now we come to the cytoplasm. Cytoplasm is where all the other organelles of the cell reside. Nucleus is the main orchestrator of all the activities. It is the largest organelle in the cell. However, it is the cytoplasm that houses a variety of the other organelles which play an important role in numerous other activities of the cell. So when you see the cytoplasm of a cell, it can either be granular or agranular. A granular cytoplasm is suggestive of the cell being possibly secretorily active. As far as the oral histology is concerned, granular cytoplasm usually suggests either of the two things. One is that the cell is rich in secretory granules and vesicles and is hence busy in producing a particular secretory product, or else it may be rich in lysosomes, in which case it may be preparing for a lytic activity. So that is the significance of a granular cytoplasm. Either it is secretorily active or it is in a preparatory mode for a lytic function. Then you have an agranular or a homogeneous cytoplasm. Homogeneous cytoplasm is suggestive of a condition wherein you do not see much of the secretory granules or the other organelles within the cytoplasm. That may be because of the simple reason that they may not be as abundant as they are in the granular condition. Hope this concept is clear. And also remember, the cytoplasm is stained with eosin. Eosin is pink. Now you have seen the individual appearance of a cell. Okay. Now let it be known that different organelles can be visualized using special stains to a greater and a much clearer extent. But we'll not delve on that now, since this is just an orientation and an introduction to very basic concepts. Now you have seen how a cell looks by itself. Now cells in the body are in harmony with other cells of a similar kind. They hold hands together and undergo a degree of stratification by which groups of similar cells appear to stack themselves one upon the other in a systematic and synchronized manner so as to perform a specific function. This property gives rise to different types of tissues. So for reference, we are going to take the oral mucosa. It will have two distinct components. The epithelial component, which is ectoderm derived and is avascular. Anything derived from the ectoderm is avascular. Epithelium is derived from the ectoderm and is hence avascular. This epithelium is separated from the underlying connective tissue or stroma or mesenchyme by a distinct border which is known as the basement membrane. So please take a look at this. Whenever you see a histological slide like this, no more looking for cover slip slides, cracks, okay? We are looking at distinct histological features. Look at the staining characteristics. See the extent of pink and blue here. I told you, look at the size of the cell, look at the shape of the cell, look at the number of the cell, and look at the arrangement of the cell. Everything should come together in a smooth flow right now. Look at the staining here. It's totally pink. As you go down, the extent of pink is slowly reducing and you're seeing more of blue or hematoxylin stain. That is because the nucleus is gaining greater prominence as you move towards the basal cell layer. On the surface layer, the nucleus tends to be much more redundant and non-functional because these cells are on their way out, whereas the cells in the basal and the parabasal layers are the ones that are more secretorily active and mitotically active. Hence, these cells have a much more intensive staining pattern. Now, this epithelial component is separated from the mesenchyme derivative or the mesoderm-derived connective tissue, which is also known as the stroma, right? Now, the stroma is characterized by ingrowths of epithelium, which are known as rete ridges. and the epithelium is distinguished from the connective tissue by a distinct pink border, which is called the basement membrane. This concept is common for every slide of histology that you will see, be it a gland, be it mucosa, be it even an odontogenic apparatus under histology. You will find an epithelial component, you will find a connective tissue component. The only difference being the epithelial component is monotonous. There is only one population of cell which resides in the epithelium, whereas the connective tissue is much more diverse. You find a large array of structures within the connective tissue because they are the ones which replenish the nutritional requirements of the epithelium. Hope this concept is clear to you. Epithelium, connective tissue, and a distinct basement membrane. The basement membrane can be stained using a special stain called periodic acid Schiff. Periodic acid Schiff. Okay, this stains the glycogen in the basement membrane and gives it a distinct magenta color. We'll be seeing its significance sometime later during the presentation. Now you know what is normal. Now there are different abnormalities which can occur in the epithelium. Look at this. See the pattern here. There is a distinct connective tissue retirage interface. Yes, and there's a distinct thickness of epithelium which is maintained, and equilibrium is maintained. Look at this diagram here. This is the normal thickness of the epithelium. However, when you go here, see the size? Are you able to distinguish the variation in size? See this and see this. There is an increase in the number of cells here. This is known as hyperplasia. So this is what will directly translate into any say nodular or papular lesion that you see on the oral mucosa or on the skin. If you take a biopsy specimen from there, what you're going to see is hyperplastic epithelium. That is epithelium which is initially normal. See, you should always have normal tissue as a reference. See the normal epithelium, which then grows inward and becomes larger, hyperplastic. On the contrary, certain cases which are associated with mild to moderate inflammation may exhibit what is known as atrophy. Atrophy is where the epithelium appears much thinner and stretched out than normal. It's much like blowing air into a balloon. Once you blow air into the balloon, the membrane of the balloon tends to stretch and become translucent. That's the same thing which is happening with the connective tissue. If the connective tissue below is becoming hyalinized or extremely dense or overpopulated with inflammatory cells, it tends to push into the epithelial space and hence makes the epithelium look a lot more atrophic. So that's your epithelial atrophy. Now the third parameter is where the epithelium is completely missing. That is, there is a discontinuity in the surface epithelium. This is known as ulceration. So you can see here, there is epithelium here, there's epithelium here. But in the middle, there's nothing. There's just dense blue dots. These are suggestive of the nuclei of the inflammatory cell infiltrate. So this is an ulcerated epithelium commonly associated with trauma. So these are the three basic types. Now, look at this picture, which is the normal epithelium, and look at this picture. Are you able to spot a distinct difference here? The cells here are a lot cohesive to one another. They exhibit cell-to-cell adhesion because of intercellular junctions. Here what happens is the cell junctions are broken. And because of this simple fact, almost all vesiculobullous lesion specimens that you observe under histopathology will appear to have a discohesion between the cells. The cells will not be adherent to one another. You'll find empty spaces within the thickness of the epithelium at varying stages or varying heights of the epithelium. This is suggestive of a vesiculobullous lesion. Of course, you'll have to do more immunohistochemical staining or immunofluorescent staining to determine which type it exactly is. Okay, so ulcerated, yes. Ulcerated epithelium is where there is a loss in continuity of the surface epithelium. Just take a look at this picture. Epithelium here, you can see epithelium here, isn't it? However, in this area, there is nothing. There is no epithelial cell, there are no retirages. All you can see is a denuded surface here and a lot of bluish dots present over here. This is suggestive of an intense inflammatory cell infiltrate, which is commonly associated with most ulcers. This is the histological picture of an ulcer. Hope that's clear to you. Yes, the connective tissue will have change. As you can see here, as I mentioned previously, there are a lot of blue dots that you can see here, isn't it? Are you able to see these dots here? These are intense inflammatory cell infiltrates, which is suggestive of inflammation. So look at these dots present over here, these spaces. These are your blood vessels. Okay, right. So moving on. Next, you will see what are known as mitotic figures. Mitotic figures are suggestive of the cell undergoing multiplication. Note that, look at the nature of the nuclei here. What type of nuclei are these? Yes? What type of nuclei do you think are these? Are they open-faced or closed-faced? They are open-faced. Good. They are open-faced or vesicular nuclei, which is suggestive that the cells are metabolically active. Look at these structures which are present here. These dark hyperchromatic structures, these are suggestive of different stages of the cell cycle, suggestive of the cell being in an attempt to multiply or divide. So this could be your anaphase, this could be your metaphase. Okay, you will find in normal histology such structures will be found localized to the basal and the parabasal layers of the epithelium, whereas in pre-malignant lesions or conditions where the cells are exhibiting increased proliferation, for example your squamous cell carcinoma, you will find a large number of cells exhibiting these mitotic figures. They will be present throughout the cell thickness. So these are your mitotic figures. Next, let's just talk about how odontogenic epithelium appears under normal histology. Odontogenic epithelium, on contrary to your basic mucosal epithelium, is much more smaller. They are smaller, flattened cells without a very prominent nucleus and a very scant cytoplasm. So you'll find these tiny cells which are present here with scant eosinophilic cytoplasm around it. The reason for this being most of the odontogenic epithelium that we come across in routine histology are rest cells. They are resting cells because they have already performed their function, and the result of that is our odontogenic apparatus, isn't it? So because of that, most of the time odontogenic epithelium will appear inactive or in a resting state, and hence the nuclei appears hyperchromatic and the cytoplasm will appear pale and eosinophilic. The cells appear much smaller in size. So that's your odontogenic epithelium. It's very important to know this because odontogenic epithelium can manifest in varying types of lesions like odontogenic cysts and tumors. Now we move on to the more diverse component that we usually associate with the connective tissue. So connective tissue can be, in normal oral histology, it's usually loose and fibrous connective tissue. So you will find eosinophilic stroma like this, which is also known as the ground substance, in thread-like fashion, S-shaped thread-like fashion with flattened cells dispersed throughout. These flattened cells are your fibroblasts. They are the most abundant cells in the connective tissue. So these cells are what produce this ground substance, and this is what gives the pliant nature of the oral mucosa. The nature or distribution of this ground substance determines the nature of the oral mucosa. For example, if you pull your cheeks or you stretch your lips, you're able to do it very easily, isn't it? It's very pliant. That is because this ground substance appears like this, like thin fibrils. Okay. However, in the palate, if you see in the palate, the connective tissue appears a lot more denser. It's like this. The connective tissue fibers are a lot more thicker, lot more mature, as a result of which you'll find fewer cells in between. The cells will not be as abundant as they are in your loose fibrous connective tissue. And this in turn determines the nature of the dense and tenacious hard palate and gingival mucosa. Okay, these are two normal histological specimens. However, you can also see certain degree of abnormality in myxomatous connective tissue and hyalinized connective tissue. Myxomatous is jelly-like. Myxoma means jelly-like substance, as a result of which that jelly-like consistency of the tissue specimen translates to this nature of histology. Note the staining property here on the right of normal loose connective tissue, and note this. Isn't this much paler? It's extremely pale pink, isn't it? However, this is a slightly darker pink. That is because in myxomatous tissue, the cells produce a lot of ground substance. And this ground substance tends to get diluted during staining procedures and tends to get this pale pink appearance. And this is what is responsible for the gelatinous nature in odontogenic tumors like myxomas. Another type which you see is called hyalinized connective tissue. Hyalinized connective tissue is basically a step further from dense fibrous connective tissue. After the connective tissue is dense and fibrous, the next stage is hyalinization of the connective tissue. That is because normally in a connective tissue, you will find there is regular deposition and degeneration. So this maintains the consistency of the connective tissue. However, in hyalinized connective tissue, what happens is the resorption of the connective tissue is overpowered by deposition. So what is laid down continues to stay there, mature, and eventually become uniform, eosinophilic, and glass-like. This term glass-like is very important in context of hyalinized. So see this, it's pale pink glass-like. You're not able to delineate fibrous pattern here. See this? It's extremely pale. This suggests that the connective tissue is extremely mature and extremely dense. Hyalinized connective tissue, for example, the best example you can give is advanced oral submucous fibrosis. If you have observed a patient with advanced submucous oral fibrosis, the mobility of the mucosa is extremely compromised. The patient cannot open his mouth hardly for 1 finger thickness, isn't it? So that is because the connective tissue is extremely dense and mature. It's become hyalinized, and hence the pliant nature is lost. So this is hyalinized. The important thing here is in hyalinized tissue, the cells, the fibroblasts and the blood vessels tend to get crushed or compressed because the connective tissue is so dense that it tends to spread out and occupy all the space. And eventually the overlying epithelium also becomes atrophic. Other stromal inmates include your muscle fibers, which appear like so, in longitudinal sections like strands like this, and in transverse sections, polygonal in fashion with peripherally placed nuclei. Again, the main tissue is eosinophilic, while the nuclei are hematoxophilic. Okay, you want myxomatous. Okay, let's just move behind. Just a minute, please. Myxomatous is a condition wherein the cells are overproducing connective tissue, which remains in a gelatinous fashion. It's basically an advanced stage of loose fibrous connective tissue. So here what happens is the connective tissue takes up a much more gelatinous consistency because of the increased looseness of the ground substance. So the ground substance does not undergo adequate maturation. That is, the cells are a lot more active, but the ground substance does not undergo maturation because there is not much time. The ground substance keeps getting replenished. So there is not much time for the existing ground substance to get maturized or dense, as a result of which you get this gelatinous pattern, which is also known as myxomatous. Myxomatous is seen in odontogenic myxoma. Odontogenic myxoma is the most common example for myxomatous connective tissue. Okay. Hope that's clear. Shall we move on? Okay, good. Next, you have muscle fibers, as I told you. Then you have neural tissue. Neural tissue in transverse sections can look like this. bundles of neurons. You can see the perineurium here. You can see the epineurium here, yes, with peripherally placed nuclei. Whereas in a longitudinal section, you can see this S-shaped or wavy pattern, which is reminiscent of nervous tissue. S-shaped pattern. Look at this S-shaped pattern. Arrangement of cells. Remember, I told you arrangement. Arrangement is S-shaped for neural tissue. Then you have capillaries, blood capillaries, very basic. You will find a lumen like this. What is a blood capillary? It's just a tube, isn't it? It's a tube with corpuscles running within it. So if you take a transverse section of it, what you're going to see is a empty space like this, filled with, not exactly empty, filled with red blood corpuscles and lined by these endothelial cells. Adipocytes, on the other hand, will appear like empty luminated structures, devoid of any nuclear composition or any other contents whatsoever. That is because of the simple reason that during tissue processing, we are using a lot of organic solvents. Organic solvents tend to dissolve lipids, as a result of which adipocytes appear as these empty vacuolar spaces. Glands. Glands will appear lobulated. You'll find these lobulated acinar structures. These are called acini. Look at this. You'll find this pattern here. If you observe very closely, look at this acini, this particular acini, you'll find these individual acinar cells like this, lying in close approximation to this luminated structure lined by tall columnar cells. This structure is a duct, and these are your acini. Note the structure very carefully because it's very important for salivary gland histology, also comes into play during various salivary gland malignancies. Then you will also have bone. Bone will have this typical lamellated appearance. Bone, when you think of bone, think of onions. Ever cut an onion? You will find lamellated patterns. You'll find annular pattern of arrangement. That is called lamellation. So you'll find these lamellae with some empty spaces with cells here, and these secretorily active cells called osteoblasts lining the bony tissue. So these are your stromal inmates. So now you have an understanding as to how epithelium looks, how connective tissue looks, what are the different components of a normal epithelium, what is the nature of the basement membrane which distinguishes epithelium from connective tissue, what is the special stain used to stain the basement membrane, and what is the nature of the connective tissue with the different stromal components. Hope this entire thing is clear to you. Yes, because now we will be testing whether you can distinguish normal histology from pathology. So hope you're ready. Let's move on. The basic hint or tip that you can take away from pathology is that the histopathology will often mimic the clinical picture. So what you see in the patient's mouth, that is why it is never one-handed. You can never clap with one hand, isn't it? You always need two hands. One hand is your observation of the clinical specimen, at best the patient's oral cavity or the biopsy specimen, and the other hand is your histopathology. So you have to correlate. So the moment you see the tissue specimen or the lesion per se in the patient's mouth before it is excised, you can directly visualize how the histology is going to look. Keeping this basic fact in mind, look at this lesion. Okay. This discussion will be a lot more picture-based because lots of pictures are coming in your entrance exam. So it's important that you see a lot of pictures, familiarize yourself with clinical and histopathological pictures. Look at this lesion on the dorsum of the tongue. It's nodular, right? Can you see areas of white? That suggests it could be keratinized. There are areas of keratinization, correct? Can you see? No, I'll come to the diagnosis. Look at this reddish area here. Reddish area here. Okay. Okay. Now you see, you have seen slight area, a nodular lesion with areas of keratinization, with areas of erythema and ulceration. When you see erythema and ulceration, expect loss of continuity in the epithelium, expect an intense inflammatory cell infiltrate, expect vasodilation. You just have to correlate your general pathology features of inflammation to histology. Keeping this basic fact in mind, look at the histology. This entire thing was excised, and what you see are, look at this. See the size of the epithelium? Hyperplastic, isn't it? That corresponds with these nodular and keratinized areas. Wherever you see nodular lesions, there will be some area of keratinization because the body is trying to shield off the possible cause of trauma or insult. So that is seen as a protective mechanism, and you will see hyperplastic epithelium correspond to the adjoining epithelium. See the size here and see the thickness here. Got this? Then you find no epithelium here. See this? One of you were asking about ulcerated epithelium. This is a classic picture of ulcerated epithelium. You can see epithelium on this side and on this side, but nothing in between. This is suggestive of ulcerated epithelium. And here you find dispersed areas of bluish patches. And you see some empty spaces here. Now you start zooming in, move into higher power. What you see is these bluish patches were actually dense inflammatory cell infiltrate. And these empty spaces are engorged, dilated blood vessels. This is suggestive of a pyogenic granuloma. Whenever you come across any histological specimen, correlate always with the clinical history and start with simple things. Okay? Uncommon things are really uncommon. There's a reason why they're called uncommon, because you don't find them in routine examinations. Unless you rule out your simple diagnosis, only then can you move upwards in the diagnostic hierarchy. So always look at simple diagnosis and then move on to the others. If you take syphilitic gamma as a possible diagnosis, you wouldn't be wrong based on the clinical picture. But you have to see the histology, you have to look at the microbiology, you have to take a possible, you definitely have to take a clinical history to rule out syphilis, because that is a microbial lesion. Okay, it comes as a part of tertiary syphilis. So in such cases, you have to ask the patient about his or her previous history, occurrence of lesions like this previously, or the nature of those lesions, and the window period between the occurrence of these lesions. All these play an important role in making a diagnosis. However, in this case, the simple diagnosis would be pyogenic granuloma. Moving on to another example. Yes, this patient reports to you with reticular lesions on his buccal mucosa. Okay. You can see whitish lesions here, slightly raised above the normal surface. See, this area is slightly normal in between, slightly raised up, reticular interconnected pattern. Okay, it resembles a lace-like arrangement. Other than this, you are also seeing reddish areas in between. Can you see these areas of erythema in between? Yes? No, careful. 1 minute. Do not jump to the diagnosis immediately. Do not jump to the diagnosis immediately. Look at all the clinical features, and we are talking about oral pathology. So look, you have the luxury of histopathological specimens. So take your time and make the diagnosis. This patient is reporting to you with linear reticular lesions with foci of inflammation. These lesions are non-scrapable. They happen to be bilateral in the buccal mucosa. Now it rings some bells, isn't it? Better. That's better. Now it's lichen planus. Now, what I want you to see is the histology. Diagnosis, very good. It's lichen planus. But what I want you to see here is, what I want you to appreciate is how this clinical picture translates directly to histology. This is so important because if you know the clinical picture, you do not have to by heart the histology. So from this, you know, you are going to see areas of keratinization because of the white. You are going to see areas of epithelial hyperplasia, mild to moderate epithelial hyperplasia, because of the raised nature of the lesion. You are going to see intense inflammatory cell infiltrate because of the reddish nature of the lesion. Is this clear? Yes? So now look at the histology. Textbook oral lichen planus. You're seeing the hyperkeratinization. Yes? You are seeing a belt of inflammatory cell infiltrate. It's just like a belt. This is your shirt, this is your trouser, and this is your belt. This belt is your intense inflammatory cell infiltrate of cytotoxic T cells. This is directed at self-antigens produced by the basal cell layer. Because there are self-antigens produced against the basal cell layer, you cannot distinguish a basal lamina very clearly in a case of typical oral lichen planus. Look at this. Can you see this area? You're not able to distinguish where this ends and this begins. That is because of the war zone which is created here at the junction of the epithelium and the connective tissue. That is because of the simple fact that the cytotoxic T cells are attacking the own body's host cells and causing cell death and destruction at this junction, causing the basal lamina to fade out. So you have an indistinct basement membrane. When there is intense inflammation, always there will be release of interleukins and cytokines, as you will be seeing in basic pathology. As a result of cytokine release, the epithelium will try to multiply. Cytokine, cyto-cell kinesis mobility, right? So the cells will try to move to that particular site and try to multiply. That applies to inflammatory cells, that applies to epithelial cells. That is why you see these sawtooth retiridges. Look at these sharp retiridges. That is because these cells are multiplying. The cells here are multiplying and hence moving into the epithelium. However, they are held in space by the basal lamina. In such cases where you cannot see the basal lamina clearly, in conditions like oral lichen planus, in pre-malignant lesions, you will need a special stain called periodic acid Schiff. Is this concept clear? Are you able to translate the clinical picture to the histology very clearly? Yes? So let's get moving. Okay, good, good, good. One more example, and then we move to the second part of our discussion. Okay, this lesion, tobacco chewer, whitish patch of raised lesion present here on the buccal mucosa, right? Duration of about 3 to 4 months. And there is some amount of ulceration also present peripherally. But predominantly this lesion appears hyperplastic. So at this point, you can give a clinical diagnosis of leukoplakia. Yes, leukoplakia is always a clinical diagnosis. You will never use leukoplakia in oral pathology, usually. We use dysplasia. We say epithelial dysplasia. Okay, leukoplakia is a white lesion of unknown etiology. So leukoplakia can be one of the differentials, but here the etiology is unknown. It's not unknown. You know that he's a tobacco chewer. He's keeping the pouch there. Yes. So you are going to look in terms of epithelial dysplasia. Very good. You're going to expect epithelial dysplasia. You are seeing a slight outgrowth of epithelium. It's not in flush with the surrounding epithelium. So you can expect an early invasive squamous cell carcinoma also, judging by the severity and size of the lesion. Keeping this in mind, let us see the gross specimen. So this sample was excised and you are seeing a specimen like this. This specimen was excised. This is how it will come to us. When we see it for pathological examination, the gross study is done. Now, the clinical picture and the gross picture together will tell you far more. You will get about 40% of the information from these two pictures. And then you can confirm it using your histopathology. Now, what I want you to follow very closely is this. This is the outline, okay? So this white area, whenever you see a gross specimen, the white area is epithelium, yellowish, brownish is your connective tissue. So you're going to see the epithelium going down like this. See this? Are you able to appreciate this? These small things you have to learn to observe. Then only you can make a proper diagnosis. Look at this. This is suggestive that there is some sort of irritant here, which is causing the epithelium to multiply to a much greater extent than normal and grow into the connective tissue. This is called Yes, exophytic or endophytic? Endophytic. It is going into the connective tissue, isn't it? It's going into, very good. It's going into the connective tissue. Okay, so now you see the histology. Look at this. See this? The same thing which I drew there has translated histologically. You are seeing white. See the amount of keratin deposited here. Yes? You see, note the outline of the connective tissue. Yes? It is an endophytic lesion. So on closer examination, you will definitely see foci of epithelial dysplasia. Okay? In such cases, you can give a diagnosis of verrucous hyperplasia because it does not have an exophytic component, it's just an endophytic component. If it had exophytic and endophytic component, then you start thinking in terms of something called a verrucous carcinoma. But here you have a verrucous hyperplasia where the epithelium is hyperplastic and it is moving in endophytic pattern into the connective tissue. Whenever you observe a connective tissue, no, do not go to pemphigus because you are seeing a continuity in the epithelium. If you are giving your judgment of pemphigus based on this space here, I suggest we don't do that because this is the surface epithelium. Note the difference in staining here in this area and this area. This is a lot more darker. That is because this is pure keratin. Keratin is deposited. Once keratin is deposited, it's not as adherent as epithelium. Keratin tends to get discontinuous at certain points in time. So that is what gives rise to these empty spaces. So don't take them for granted. Always correlate with the clinical picture. A vesiculobullous lesion will never be keratinized. Simple fact, isn't it? A blister will never be keratinized. A blister will always have inflammation, ulceration, erosion. So you have to look for ulceration or atrophy of the epithelium when you're looking at a vesiculobullous lesion. Hope that concept is clear to you. Yes? So here we make a diagnosis of epithelial hyperplasia. Whenever you make a diagnosis of epithelial dysplasia, moderate to severe epithelial dysplasia, it is always advisable to do a per iodic acid shift staining for the basal lamina so as to identify the continuity of the basement membrane. Yes. What is your doubt exactly, Dr. Yash? Is it regarding how to rule out pemphigus in this case? Okay, so let's start with the clinical picture. Look at the picture clinically. Clinically, there is no denudation of the epithelium. 90% of the lesion is keratinized. 90% of the lesion is keratinized. Okay, it is keratinized and is not much elevated from the surface of the epithelium. This suggests that the lesion is keratinized on the surface, but it could be growing inwards. We do not know. So you rule out a vesiculobullous lesion because of the simple fact that the clinical picture is not ulcerated or denuded epithelium. Number one. Number two is the histology. Histologically, you will see a large mass of epithelium like this. And it's called endophytic because it is growing into the connective tissue. Had it been exophytic, this is your doubt, Dr. Sujay. Had it been exophytic, you will find a proliferation of epithelium outwards. So here, just look at the gross specimen. I'll just draw it, how an exophytic lesion would have appeared. This area would have been a lot more protuberant like this. Here you're finding a smooth surface lesion like this, and the undulations and the protrusions are reserved for the connective tissue interface. This is suggestive that it is an endophytic lesion. Okay. The second thing which you were asking regarding vesiculobullous lesions, the surface, the discontinuity or the disadhesion between the epithelial cells will be found throughout the thickness of the epithelium, not localized to a particular spot like this. Okay, and this is the surface keratin. The epithelium is only in this region. This part is epithelium. This part is keratin. Keratin is easily lost. It's denuded. Yes, when it gets denuded, it gives rise to such empty spaces. Hope this is clear. All good? Okay. Let's move on now to the second part of our discussion. This is a small part. Introduction to odontogenic cysts. Now let's introduce ourselves to some form of odontogenic pathology. Now you have seen quite a bit of mucosal pathology. Now let us start seeing something about odontogenic pathology. So let's introduce ourselves to odontogenic cysts. First of all, you should just know what is a cyst. By definition, a cyst is a pathological cavity which is filled with fluid, lined by epithelium, and contains fluid, semi-fluid, or gaseous content, not pus. A cyst will not be characterized by accumulation of pus. This is the definition of a cyst. Any cyst, okay, any true cyst. Now, as far as any cyst, any true cyst is concerned, for that matter, let's talk in pertinence to odontogenic cysts. You will have three components. Every cyst has three components. What I'm telling you is common histology. What I told you previously also was common histology. Any nodular lesion will look like that. Any ulcerated lesion will look like that. Any keratinized lesion will look like that, as we saw previously. Okay, so any cyst is going to look like this. There will be three components for a cyst. There will be a lumen, there will be a lining, there will be a capsule. Three components. Again, see, even in a cyst, you have an epithelial component and a connective tissue component. Are you getting the continuity? You should always have a flow from histology to pathology. That is what makes the study much more interesting. Yes, and much more involving. Okay, so here you have the lumen. This is the lumen, or the empty space, which is filled with fluid. This fluid is lined by an epithelial layer. That is called the lining. And then you have a capsule which comprises of connective tissue, which delineates the outlines of the cyst. It delineates the outlines of the cyst. So these are your histological components of a cyst. All these things can be delineated to a certain extent on gross examination. If you get a cyst, you're going to get a bag of tissue. That's what a cyst is going to look like. So you're going to take a transverse section. When you do that, you'll see an empty space and you'll see a tissue surrounding it. That's all you can see grossly. But when you go deeper, this is what you will discern. Now, based on the nature of the lining epithelium, or based on the parentage of the lining epithelium, or the lineage of the lining epithelium, you are going to classify odontogenic cysts. Got this? There are three types. The first one are the cysts that arise from the rests of molasses. Now, for this, you should know what are rests of molasses. Rests of molasses are remnants of what are known as the Hertwig's epithelial root sheath. Okay, rests of molasses are remnants. Very good, Amrita. It's very good. They are remnants of the Hertwig's epithelial root sheath. Now, for this, you should have an idea about odontogenesis. The outer and inner enamel epithelium meet at the cervical region to form the Hertwig's epithelial root sheath. They grow downwards like this, 1 or 2 cell layer thick, and they will delineate the dental papilla within it, enclose the dental papilla within it, and allow for the development of the root dentin pulp complex. Once this is done, so just look at my hands once. These both my palms represent the Hertwig's epithelial root sheath. This point, when my palms approximate, represent your future apical foramen. Okay. Now, within this, the root dentin and the pulp tissue mature. When they mature, they increase in volume, isn't it? They increase in volume. When they increase in volume, this Hertwig's epithelial root sheath stretches. Finally, it undergoes disintegration. When it undergoes disintegration, it gives rise to rests. These cells tend to lie in the surrounding ectomesenchyme, and they are called rests of molasses, which are remnants of the Hertwig's epithelial root sheath. Once this happens, the outlying dental follicle will come in contact with the root and deposit cementum there. So these rests, they are called rests because they are resting cells. They have no function after that. However, under certain pathological conditions like a non-vital tooth or a grossly carious tooth, they can undergo reactivation to give rise to your periapical cysts or residual cysts. The next are your rests of serrae. Now, the tooth organ is initially connected to the oral epithelium because it is from the oral epithelium that the tooth bud drops down into the ectomesenchyme and develops into a tooth. It's a cycle of life sort of thing. Okay, it starts from the oral epithelium. Look at my hands, please. Starts from the oral epithelium, gets pinched off, goes downwards. At this point, it is connected to the surface epithelium by a strand of cells called the dental lamina. Once the tooth bud has formed, this strand of cells gets cut. So the tooth bud comes to lie as an independent, individual, self-functioning, self-sufficient entity within the ectomesenchyme. There it starts undergoing specialization, giving rise to the tooth bud. So in the meantime, what happened is this group of cells got cut, isn't it? They're like a ribbon cutting. It got cut. So these cells became rests. These rests of dental lamina are called the cell rests of serrae. Got this concept? You have to only understand at this point in time how the rests of serrae came into being, right? And then you have KCOT, gingival cyst of newborn, glandular odontogenic cyst, and the lateral periodontal cyst. Then you have the third group of cells, which is your reduced enamel epithelium. Reduced enamel epithelium tends to lie on the surface of the newly formed crown, protecting it from the cells of the dental follicle. So the cells arising, the cysts arising from the reduced enamel epithelium are dentigerous cyst and eruption cyst. Very easy to understand. The concept should be very clear. You should know where reduced enamel epithelium lies. So this is your tooth. This is reduced enamel epithelium. Now imagine if fluid gets collected between this lining epithelium and this tooth structure, what will happen? Yes, you are going to find something like this. This epithelium will get pushed open here and you'll get an accumulation of fluid here. That is why a dentigerous cyst is always associated with an impacted tooth and a large follicle. Now you're able to correlate this. Yes? Good. The previous slide. Okay, 1 minute. Erase this. Okay. This one, rests of serrae. For this, you should know how the rests of serrae come into being. Now, the oral epithelium gives rise to ingrowth of epithelium, right? Which in turn matures into the tooth bud. Okay, this ingrowth of epithelium is called the dental lamina. The dental lamina eventually undergoes specialization to form the tooth bud. The dental lamina gets cut over a period of time, that is usually towards the bell stage. When it gets cut, this area, this part where my cursor is, this part gets severed. So these cells will lie in this connective tissue as rest cells. These rest cells are called the cell rests of serrae. These cell rests of serrae on appropriate stimulation can give rise to a variety of odontogenic cysts. These include your KCOT, glandular odontogenic cyst, and lateral periodontal cyst. Hope this is clear. Okay. All good? Okay. Good. So now you have your reduced enamel epithelium, which is present here, which gives rise to your dentigerous cyst and your eruption cyst, as I mentioned previously. Which part do you want, Dr. Sujay? Which part would you like me to repeat? Is it the reduced enamel epithelium or the rests of serrae? Yes? Rests of serrae. Okay. Okay. Just understand this. Odontogenesis starts from the surface epithelium or the oral epithelium. Okay. From the oral epithelium, it starts as an ingrowth of epithelial cells like this, like a strand of cells. This strand of cells which grows downwards is called your dental lamina because it gives rise to the dental tissues or the tooth bud. This much is clear? Dental lamina. Okay. Now the end, the distal end of the dental lamina gives rise to what is known as the tooth bud. The tooth bud at a later stage gives rise to enamel, dentin, and the whole tooth as we know it. That's why it's called the tooth bud. Okay. For this specialization to occur, the dental lamina, this connection with the oral epithelium here is connected to the ectomesenchyme here. This connection of the dental lamina has to be cut here. Okay. When this gets cut, these cells of the dental lamina are jobless. They are jobless. Hence, they lie as resting cells within this connective tissue. These rests of the dental lamina are called rests of serrae. Okay. Dr. Yash, is this clear now? Okay. Good. 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 So now let's move on. Reduced enamel epithelium, you saw dentigerous cyst and eruption cyst. Okay. Now a brief note on radicular cyst. Just to tell you the most common odontogenic cyst. It is the most common odontogenic cyst because all of these things have been asked directly as questions. It's inflammatory in origin, associated with a non-vital pulp. A radicular cyst is always associated with a grossly carious tooth or a non-vital pulp. That's the most important prerequisite. And it is the most common odontogenic cyst. These two have been asked repeatedly in entrance examinations. Alternate names are your paradental cyst and inflammatory collateral cyst. Okay. And it will present initially as a bony hard swelling, which later undergoes eggshell crackling. Eggshell crackling is because the cyst is growing within the bone. Okay. Now you saw previously how the bone has a pattern of trabeculations, right? So if this hand is the bone, it's like a balloon growing within the bone like this. So what happens is the trabeculae, which are my fingers, get stretched out like this. Okay. So when you palpate it, you crush small trabeculae of bone. That is known as eggshell crackling. Eggshell crackling is not pathognomonic to radicular cyst. It is seen in many other intraosseous lesions. But just remember it, it is commonly in odontogenic cysts, it is seen with radicular cysts. Radiographically, you see, always you will find a large restoration with impingement on the pulp, as a result of which you find this large radiolucency present, well delineated from the surrounding tissue. Sometimes a periapical cyst can exhibit direct continuity with the apical foramen, in which case it is called a bay cyst. A radicular cyst exhibiting direct continuity with the apical foramen is called a bay cyst. Now this is the pathogenesis. For this, you should know exactly what is happening in, what's the cause of a radicular cyst. It's a deep caries. So this is your deeply carious tooth. It has touched the pulp. It has reached the periapical region and caused a periapical infection. Okay. Now, what is the response of the body to an infection? It's chronic inflammatory response, isn't it? Chronic inflammatory response is characterized by formation of what is known as a periapical granuloma, like this. Look at this image. Granuloma means there is, when this infection reaches here, large number of inflammatory cells come here, large amount of cytokines are released. This in turn promotes proliferation of cells here. Which cells? The rest cells. Which rests? The rests of serrae or molasses? Come on, quick. Yes, very good. Cell rests of molasses. So these rests were sleeping here quietly. Suddenly, these cytokines come and ring an alarm bell in the ear of the rests of molasses. So they will multiply like this. When they multiply like this, good. When they multiply like this, a population of cells is formed here, a granuloma. Along with that, there will be large number of blood vessels here. So what happens is these blood vessels are close to the outer layer of cells, isn't it? These cells in the outermost lining of the cell proliferation are having access to the blood. The cells in the middle have no nutrition, so they die out. They undergo liquefaction necrosis. When this happens, you get a cystic lumen like this, lined by these epithelial cells or rests of molasses and an highly inflamed connective tissue. This is how a radicular cyst comes into being. Is this concept clear? Very easy. Inflammation comes, foci of inflammation develops, cytokines move in, granuloma formation occurs, rests of molasses multiply, central area undergoes degeneration, and you eventually get a cystic lumen with a lining and capsule. Clear? Okay. Histologically, that is what exactly it translates into. Look at this. I showed you, you remember the lichen planus slide? Do you remember the sawtooth retiridges? Do you remember the sawtooth retiridges? The retiridges were sawtooth because of the intense inflammation which was around it. Whenever there is inflammation, the retiridges will appear like this, sawtooth shaped, or they will start developing arc-like pattern. They will tend to become arc-like. That is called an arcading pattern of lumen. Arcading pattern. Look at the arcs. See here. See the arcs here. 1, 2, 3. Yes. Arcading pattern of epithelium is seen, along with dense blue pattern. That is lot of inflammatory cells. Lot of inflammatory, because it's a product of inflammation. So you are going to see inflammatory cells, you are going to see RBCs, you're going to see a lot of cell death. So when a lot of cell death occurs, the cell membrane discharges its lipid contents and cholesterol contents into the capsule, as a result of which you will find these empty rhomboidal spaces within the matrix, which are called cholesterol clefts. This is basically cholesterol from the cell membrane of lysed RBCs or lysed host cells. So this is what you find here: arcading pattern, dense inflammatory cell infiltrate, and cholesterol clefts. Okay. Right, moving on. You will also find hyaline bodies. Hyaline bodies are also called Rushton bodies or Russell bodies. So this is again another byproduct of intense cell death. So when the cell death occurs, it results in pooling and coagulation of serum proteins and a release of inflammatory exudate. This inflammatory exudate results in these curvilinear shapes. Curvilinear means hairpin shaped. Have you seen a hairpin? It is curvilinear. Look at this structure. It's curving here and it's linear here. Okay, so this is called a Rushton body or a hyaline body. This is characteristic of inflammatory cysts, and in this case, the radicular cyst. Okay, the easy way to identify a hyaline body is it will appear refractile. That is, when you can focus these cells in the background, the hyaline body will appear blur. That is called refractile because the refractory index varies. The refractory index of the hyaline body varies from the epithelium. Hence, it appears refractile. So, hyaline bodies. Okay. Now, residual cyst is a variant of radicular cyst which occurs when even the causative tooth has been removed. That is, supposing a grossly carious tooth was there with an associated radicular cyst, you are removing the tooth, you are extracting the tooth, and you are trying to remove some of the cystic tissue which is present there. However, you have left behind some amount of potentially, some amount of cells which have a potential to give rise to the cyst. So over time, a cyst occurs at that particular site again with histology similar to a radicular cyst with much lesser inflammation. This is called a residual cyst. It's a residue. It's a residue of a previously present radicular cyst. So when you talk radicular cyst, you should know it's an inflammatory cyst. You should know the alternate names. You should know the cell of origin. You should know the variants, that's the basist and the residual cyst. And you should know the pathogenesis and distinct histological features. That is arcading pattern, intense inflammation, hyaline bodies, and cholesterol clefts. Fine? Good. On that note, let's start a few questions. Which of the following is the most common odontogenic cyst? Yes. Easy. Very easy questions. I just want to warm you up into oral pathology. Let's not go hard directly. Okay, good. It's radicular cyst. Radicular cyst is correct. Good. Which of the following develops from the reduced enamel epithelium? Reduced enamel epithelium is dentigerous cyst. KCOT develops from which cells? KCOT. KCOT develops from which cells? Cell rest of serrae. Very good. KCOT or keratocystic odontogenic tumor is the other name for odontogenic keratocyst. Okay, that's the old name. Now it's considered a tumor. Active odontoblasts may present with which of the following features? Active odontoblasts. Yes, come on. Our first slides. Active odontoblasts. Yes. They have. Careful, careful. No. Active odontoblast will only have an open-faced nucleus. Open-faced nucleus. Why? Because active odontoblast is secretorily active. So it will have euchromatin. Euchromatin will be dispersed peripherally, because of which the staining becomes light violet. Hence, open-faced nucleus. A resting cell will have a closed face or a hyperchromatic nucleus. Okay? Good. Which of the following patterns are seen in the lining epithelium of a radicular cyst? That's good. It's the arcading pattern. Good. It's the arcading pattern. Picket fence appearance and tombstone appearance are seen in the keratocystic odontogenic tumor. Very good, Dr. Gauri. It's keratocystic odontogenic tumor. Okay. The raining down pattern is seen in histologically is seen in botryoid odontogenic cyst, which is a variant of the lateral periodontal cyst. Raining down pattern is seen in a variant of the lateral periodontal cyst. Here the answer is arcading pattern. A special stain used to visualize the basement membrane. Come on. Yes, per-iodic, very good. Per-iodic acid Schiff stains glycogen and is used to visualize the basement membrane. A fun tip, the per-iodic acid Schiff is also used to visualize fungi. It's a special stain for fungi. Okay. Oil red O is a stain for lipids. Congo red is a stain for amyloid. And methylene blue is a stain for nuclei. Oil red O is for lipids, okay? Congo red is for amyloid and methylene blue is for nuclei. So what you have to take away from today's session, it's just an orientation. So you should understand that an open mind always sees more than an open eye. So what your eye sees, your mind has to process. So for that, you should have a proper idea of what is the theory. Now, when you see this in the water, when you're swimming and this comes towards you, what is the first thing that comes to your mind? Yes? Shark. Start praying, isn't it? Going to be eaten. Okay, so it could be shark, which is the most obvious. Or it could be a wannabe, that is someone who is not very harmful but is trying to be harmful, like this. Look at this guy. He can also come like this. Or it can be something which is very, very dangerous, much more than shark. Shark could be the least of your worries, a double-headed shark. Okay? So this is why an open mind sees more than an open eye. So you should keep all your options open. Okay. So on that note, we will be concluding today's session. Thank you for listening and hope it was useful to you. At this point, let me tell you that all the questions, this is a tip for you since you have started this journey for postgraduate training. Every question is potentially 4 questions. All the options, you should explore all the 4 options. option A, B, C, and D, you should explore them. You should study laterally. That's the only way you can cover more syllabus in less time. Treat every option as a question. Please do that. And familiarize yourself with different terms. Oral pathology has a large array of terms. You have to look at the glossary and keep familiarizing yourself with different terms every day. Keep getting new terms so that nothing looks new to you. Okay? So on that note,